Good evening, everyone, and thank you so much for joining today's webinar. We are thrilled to have you here as we dive into an insightful discussion on Meet the Investigator, the evolving landscape in the management of HR plus and HER2 negative metastatic breast cancer. To begin this session, it's my pleasure to invite Dr. Syam Agrawal sir, is a chairperson of medical oncology at Sir Gangaram Hospital, New Delhi, to deliver the opening remarks and provide us in the introduction to today's program. Dr. Agrawal, over to you.
Good evening, everyone, and thanks to the organizers for getting us together here to discuss the evolving landscape in the management of hormone receptor positive and HER2 negative MBC. So the field seems to have opened up quite a bit, especially after the availability of CDK4/6 inhibitors. Before that, we were mainly confined to using, of course, ovarian suppression, tamoxifen, and aromatase inhibitors. So CDK4/6 inhibitors have really put in life into several patients and by several years in MBC. And now we do have the understanding of PIK3C inhibitors to be used in that domain. Um, the emergence of HER2 low using TDXD has certainly changed the scenario for hormone receptor HER2 negative MBCs. We have newer agents coming in now, which are the analogs of estrogen receptor inhibitors, especially the oral ones, and they have also, brought in a lot of new changes in the guidelines, and of course, with the understanding of AKT3 inhibitors, also things have become different and better for patients who are suffering with metastatic breast cancer. And of course, all this is coupled with the understanding of the molecular biology of breast cancer and the availability of tools of next generation sequencing and sequential liquid biopsies, which gives you, insight into how the tumor is evolving and what therapy needs to be instituted. So, the on the one side, the diagnostics are getting better. On the other side, the drugs are evolving so very rapidly to change the course of the illness. So I think HR positive tumors, basically when they have the metastatic setting, is, I think, as we all know and we say, becoming a chronic disease, and people go on to live for many, many years and with excellent quality of life. So it's a model for maybe other tumor types as well to emulate. So I think today's meeting basically is to dwell on the newer trials which have been reported in the last year or so in HR positive HER2 negative MBC. So I think there are 5 or 6 such studies which will be, showcased by the experts here in the next half an hour or so, and then will be followed by our invited international speaker, Professor Curigliano, whom I think we all know because he's from Italy and is doing pioneering work in this field. And then we'll have the 2 case studies which will be moderated, one by I think Dr. Mahanti and the other by Dr. Ankur Varshne. and the discussion will be led by Dr. M.V. Chandrakant. So I think with these remarks, let's set the ball rolling. And we have the key abstract presentations. The first one being Destiny Breast 06 by Dr. Saurav Mishra, who is the professor at AIMS in Bhubaneswar. So, Saurav, over to you for the
Uh,
presentation.
So thank you for that introduction, and I would like to share my slides now. So good evening, everyone. The presentation topic for me today is Destiny Breast 06 trial. That is the use of trastuzumab deruxtecan versus physician's choice of chemotherapy in patients who are hormone receptor positive but HER2 low or HER2 ultra low in the metastatic setting who have received prior endocrine therapy. So Destiny Breast 606, it continues to explore beyond Destiny Breast 04. The Destiny Breast 04 had patients who were HER2 low, and they comprise around 60 to 65% of patients who are hormone receptor positive. Destiny Breast 06 incorporates additional 20 to 25% of patients who are HER2 ultra low. So with the use of the data from the Destiny Breast 06, it expands the proportion of patients who may benefit from TDXT, that is low and HER2 ultra low. So the definition and the inclusion criteria, HER2 low is defined as IHC 1 plus or IHC 2 plus HER2 with ISH negative, and HER2 ultra low is IHC 0 with any membrane staining. So these patients were hormone receptor positive metastatic breast cancer and they were chemotherapy naive. However, they had received more than or equal to 2 lines of endocrine therapy with or without targeted therapy. And these patients were randomized to trastuzumab deruxtecan Q3 weekly or to the choice of physician's chemotherapy, either capecitabine, nab-paclitaxel, and paclitaxel. The patients had been stratified with prior CDK4/6 use, whether they had used or not, and then HER2 expression low versus ultra low, and use of prior taxanes. Mind you, in Destiny Breast 06, the IHC for HER2 was in the most recent biopsy in the metastatic setting, whereas the Destiny Breast 04 had included primary tumors also. The primary endpoint in this study was progression-free survival in HER2 low subset, and the secondary endpoints were in the intention to treat population, overall survival in the HER2 low, and the intention to treat population. The primary baseline characteristics we can see here in the patients. So total the patients who were used, who received TDXT, the 66% of the patients were either IHC 1 plus and 32% of the patient IHC 2 plus. So a total of 359 patients in the HER2 low were IHC 1 plus or 2 plus. And in the HER2 ultra low, there were around 76 patients in each arm, HER2 ultra low patients. And the patients were all either hormone receptor positive. So either they could be ER positive or PR positive, but the ER negative, PR negative subsets were not included in this study. The patients had either primary endocrine resistant disease or they had de novo disease at diagnosis. 86% of the patients had visceral disease also at presentation, and many of them had liver metastasis also. So this was a patient which we typically we typically encounter in our clinic after progression on the endocrine therapy. And the prior therapies, if you can see here, most of the patients had received endo CDK inhibitors. So almost 88% of the patients had received prior endocrine therapy with CDK4/6 inhibitors, which are the standard of care. And then most of these patients had received either endocrine monotherapy. Almost 33% of the patients had received some form of targeted therapy, which would include either everolimus or the PIK3CA inhibitors or PARP inhibitors. And this was these patients had progressed on these treatment, and then they were subsequently randomized. Coming to the primary endpoint, there was a significant, the primary endpoint was met. The primary endpoint in the HER2 low, the progression free survival, that was 13 months in TDXT arm, and with the chemotherapy, 8 months, significant 5 months improvement in the progression-free survival. Then the secondary endpoints was in the intention to treat population, where again it was a statistically significant improvement, and therefore the study was a positive study. Overall survival in the HER2 low and intention to treat population, mind you, only the study has 39.6% maturity. It is yet to have a full maturity at this interim analysis. So there is a trend towards improvement in overall survival. However, the confidence intervals have still crossed 1. So we wait for the overall survival data. Coming to the HER2 ultra low population, so there were almost 152 patients who were HER2 ultra low. This was through a central review of the HER2 ultra low status. And in that, you can again see there was an improvement in the PFS. That is, again, this is 35% maturity. That is around a delta of 5 months, very similar to in the HER2 low subset, 13 months versus 8 months. And overall survival, as I say, because the maturity is not there. So we see here a trend, but the confidence interval crosses. More important for us in this setting would be the response rates. We can see that the overall response rates with TDXT are almost very high compared to the chemotherapy. So 32 patients, 1 in 3 patients, here 1 in 2 patients has a response, which is a partial response. Mostly, there are some complete responses with TDXT also, and as we see in our clinics, not any complete responses with chemotherapy. So the overall response rates are very crucial for our patients in this setting when they have already progressed on the hormonal therapy. So here it was a very significant with HER2 low 56%, again with HER2 low it was 62%. So definitely a very good improvement in overall response rates. If we consider with prior use of CDK4/6 inhibitors, we can see that whether the patients had progressed on CDK4/6 inhibitor between less than 6 months to more than 12 months, we can see here that the TDXT was still beneficial. So someone who has received a CDK inhibitor for more than 12 months or who has received less than 12 months does get benefit with TDXT. PFS2 is a surrogate for the robustness of the first-line therapy after the first-line therapy has been discontinued. So here we can see that the PFS2 is 20 months with TDXT and 14.7 months. So even after the patients have discontinued TDXT, subsequent treatment, whatever has been given, it could be anything, either chemotherapy, almost 20% of the patients in the chemotherapy arm received TDXT at progression, and we can see the median progression-free survival 2 is 20.3 months with TDXT and around 14 months with chemotherapy with a 5.6 months improvement. Disease burden. So even if it is a high burden disease or a low burden disease, there was a improvement in outcomes with the TDXT. We can see it on the forest plot also, whether there are liver metastases. So basically, the more high risk disease we have, the hazards ratio are still better. And overall safety coming, so this was the data for the efficacy. Now coming to safety. So median treatment duration was 11 months with TDXT and 5.6 months with chemotherapy. And as we have seen in our clinics, there are toxicities. Nausea is one important toxicity in patients who are taking TDXT. Then we have to be very careful about interstitial lung disease. Most common treatment emergent adverse event associated with treatment discontinuation was pneumonitis in 5.3% of patients. So we have to be very careful and vigilant about that. So based on this, the study concluded that TDXD demonstrated a statistically significant and clinical meaningful benefit, PFS benefit versus chemotherapy in hormone receptor HER2 low metastatic breast cancer in an earlier line of treatment, because Destiny Breast 04 had TDXD after 2 lines of chemotherapy. And the results were, more importantly, HER2 ultra low patients, the outcomes were consistent with HER2 low. So similarly, similar benefits we are getting. And no new safety signals were observed. TDXD demonstrated a clinically meaningful efficacy benefit regardless of time to progression on first-line endocrine therapy plus CDK4/6 inhibitors. Efficacy outcomes were consistent with primary versus secondary endocrine resistant, and PFS2 favored TDXT across all subgroups, also demonstrated efficacy regardless of disease burden, with notable efficacy in patients with low disease burden. So my key takeaways from this study will be, first of all and most important, in our clinic, we should now be having routinely reporting of HER2 IHC as not only 3 plus positive negative, but now we should have a very clear reporting of HER2 IHC, either HER2 low, that is 1 plus or 2 plus and FISH negative, or HER2 0 with any membrane staining, HER2 ultra low. And it should be on the most recent biopsy, because that makes it more number of patients eligible for the TDXT. Now, this is a clinically relevant option, trastuzumab deruxtecan, in this subset of patients who have progressed on endocrine therapy. Most of these patients are having a visceral crisis with the high responses which we see in these patients with TDXT. Probably we could use them in some of these patients, and which would translate into improved patient outcome. There are a couple of options in this area, like the olaparib with germline BRCA mutation, which has shown PFS benefit and with no OS benefit, and sacituzumab govitecan based on the TROPiCS-02 trial, again, which has shown PFS benefit over chemotherapy with no OS benefit. So this is something, but HER2 with such a significant delta and with improvement in PFS and with a significant response rate, we can use it in this area. There is no data for hormone receptor negative HER2 ultra low, and we await the overall survival data to use this treatment option convincingly across all HER2 low, ultra low population in the subsequent time when we get this overall survival data. That's all. So thank you again for having me, and thank you, AstraZeneca.
Thank you very much, Gaurav. I think I can see Dr. Curigliano Gaspi for the session here. I think we'll have a few abstracts presented before we go on to the professor. So I think I think we'll have questions in the end once we have all the talks.
Right.
So we can move on to the next speaker, that is Dr. Rajib Bhattacharjee, and he is going to cover Inavo 120. So he is the consultant medical oncologist at Kolkata. Dr. Raji, please.
Thank you, Dr. Gowal. It's my pleasure to present a very innovative drug that has come out very recently, and it is a PI3K alpha inhibitor, which is named as inavolisib. Quite a tongue twister there. So this is today I'm going to present the Inavo 120 primary analysis. Can you please go to the next slide? So this is the key eligibility criteria of the trial. You have the hormone positive and HER2 negative advanced breast cancer who are also PI3CA mutated, which is assessed by the ctDNA or in the blood or in the local tissue. There must be measurable disease, and they must have progressed during or within 12 months of adjuvant in hormone therapy completion. There cannot be any prior therapy for advanced breast cancer. So in a way, it is the patients were excluded if they had de novo metastatic disease, and this was the first line therapy in the advanced setting. They also excluded diabetic patients. The HbA1c cutoff was less than 6%, but a stringent cutoff, I must say. Stratification factors will include whether they had visceral disease, yes or no, endocrine resistance, primary or secondary, and also regional. The two arms, total number of patients were 325. The two arms contained palbociclib and fulvestrant, which is usually the standard of care in advanced setting. And in one arm, in the trial arm, inavolisib was added, and in the control arm, just placebo. The primary endpoint was progression-free survival, and secondary endpoint had a lot of ones, including overall survival and overall response rate. Next slide. Next slide, please. Next slide. Yeah. So these were the prior therapies, and you can see that almost all of the patients they had some sort of prior therapy, may it be neoadjuvant or adjuvant chemotherapy. It was seen in more than 80% of the patients, and 99.4. That means all of the patients they had received some sort of hormone therapy in a previous curative setting. A majority of them had tamoxifen, some had aromatase inhibitor. CDK4/6 inhibitor, we can say it was almost excluded uh, uh, from the trial. Next slide. So this was the PFS. PFS, you can say that PFS, median PFS was 15 months compared to 7.3 months and a hazard ratio of 0.43. Next slide. Overall survival, it was not reached, but as you can see that even in this situation, the hazard ratio was pretty good at 0.64, and the upper level of confidence interval was less than unity. If you see the 1 year cutoff, then the overall survival is 86% with the inavolisib arm compared to 75% with the control arm. Next slide. These were the secondary endpoints, the overall response rate and clinical benefit ratio. Overall response rate was almost 60% with the inavolisib arm compared to just 25% with the control arm. Even the clinical benefit rate was similar, 75.2% with the inavo arm compared to 47%, less than 50% with the placebo arm. So more than 50% of the patients in the control arm were progressive, whereas that was only less than 25% for the inavo arm. Quite a figure there. Next slide. So these are the normal adverse events. So the side effects that we are concerned with is mostly grade 3 and 4. So you can see that thrombocytopenia is a major one with almost 15%. Stomatitis, anemia, hyperglycemia, nausea, and rash. Nausea, they were also in quite some supply in grade 3 and 4. Next slide, please. But if you see the overview of adverse events, you can see that the number of discontinuation due to toxicities were pretty less. With inavolisib or placebo, it was almost 6.2% with inavolisib who had discontinued therapy, and almost 8%, 8 or 9% had discontinued therapy because of the hormone or the CDK4/6 inhibitor. So they were less than 10%. So that we can say that not many people had discontinued due to toxicity by the trial drug. Next slide. So this is the summary and conclusion. So addition of inavolisib to palbociclib and fulvestrant demonstrated a statistically significant and clinically meaningful improvement in progression-free survival in patients with PIK3CA mutated, hormone-positive, HER2-negative advanced breast cancer who recurred on or within 12 months of adjuvant endocrine therapy. Median PFS was more than doubled, 15 months versus 7.3 months. Hazard ratio of beautiful 0.43. Overall survival had a trend. The stratified hazard ratio was 0.64. That was also it has not reached maturity, but it's still statistically significant. So we can say that inavolisib, palbociclib, and fulvestrant has a manageable safety profile. Not much of toxicity, maybe a little bit of thrombocytopenia, but not the ones that we see with alpelisib, its other cousin. So, in conclusion, inavolisib in combination with palbociclib and fulvestrant may represent a new standard of care for patients with PIK3CA mutated, hormone positive, HER2 negative breast cancer. Next slide. So I was asked to conjure up something from my 2 cents on this trial. So these are the key takeaways and clinical implications. Inavo 120 trial has the potential to be practice changing for the treatment of these group of patients, PIK3CA mutant, hormone positive, HER2 negative advanced breast cancer. And these are my reasons. Number one, targeting PIK3CA mutation with a more selective PI3K alpha inhibitor is one important reason. Alpelisib is currently used in this setting, but it has high toxicity profile like hyperglycemia, rash, diarrhea, etc. Inavolisib is more selective for PI3K alpha. Also, it degrades the protein that this gene produces, so potentially reducing off-target toxicities while maintaining strong efficacy. the trial did not show high-grade rash or severe hyperglycemia, which are major limitations of alpelisib. Higher objective response rate that this suggests that strong tumor shrinkage, and that is maybe very important for those people who have large symptomatic disease and they are counting on the good response rate with this drug. Addresses an unmet need in first-line therapy. You need to understand that alpelisib is used in second-line therapy. But this is the first trial that tested a PI3K inhibitor in combination with CDK4/6 inhibitors in the first-line setting. And current practice in this setting is CDK4/6 inhibitor and hormone therapy, and not using PIK3CA mutation. Alpelisib is used only in second-line setting. Next slide. So what's next, according to me? Let me gaze into my crystal ball. Maybe regulatory approval will be needed before inavolisib enters routine clinical practice. If approved, it could replace alpelisib and fulvestrant in PIK3CA mutated CDK4/6 inhibitor pre-treated patients. Oncologists like us may start considering earlier PIK3CA mutation testing in hormone-positive, HER2-negative patients to guide first-line therapy, and I might extrapolate that not only this mutation, maybe other mutations will also be included in the first-line setting. Maybe we'll go for NGS that more quickly in breast cancer, just like we do in colon or lung cancer. And the INAVO 120 trial is likely to change clinical practice by shifting the standard of care for PIK3CA mutant, hormone-positive, HER2-negative metastatic breast cancer. If approved, inavolisib may replace alpelisib due to its better tolerability and improved efficacy. With that, I'll pass the baton to the organizers, and thank you for this invite.
Thank you very much, Dr. Rajib. So we're running behind schedule. So let's move on to Dr. Bhuvan Chuk. He's going to be talking about the Capitello 291 study. Dr. Bhuvan Chuk is the senior consultant at Max Hospital, Saket. Dr. Bhuvan, please.
Hi, good evening, everyone. So I'll just keep it brief and to the point. I think with the Capitello 291, can we have the next slide? So these are the patients who, men, women with a hormone-positive, HER2-negative advanced breast cancer. These patients, the Capitello 291, these patients were either primary endocrine resistant in terms of that they could have had progression while on the therapy or within 12 months of stopping the therapy, or they could have been progressed after being treated with the letrozole in the past, or basically aromatase inhibitor in the past. They did allow the previous CDK4/6 inhibition, and as we know with the PIK3 inhibitors and AKT inhibitors that the hyperglycemia is an issue, the patient had to have a HbA1c of less than 8 at the baseline. The patient was randomized to capivasertib plus fulvestrant versus fulvestrant alone, along with the placebo, and the stratification factors were liver metastasis, prior CDK4 exposure, and the region which they belong to. What is important to highlight is that 2/3 of the patient had baseline visceral metastasis, 70% had a CDK4/6 exposure, 60% patient had secondary endocrine resistance, and 40% were primary endocrine resistance. And there was a 40% alteration in the AKT pathway other than the PIK3 pathways. Can I have the next slide, please? So what we are seeing here is that so obviously the comparison which we do is with the BILIEVE trial, which was a smaller trial, and a SOLAR trial, which is a broader trial. But then we also understand that the SOLAR trial does not include prior CDK4/6 inhibitor. It was the BILIEVE trial which which included the prior CDK4/6 exposure. So what was seen with Capitello was that in a patient who had a PIK3CA or AKT pathway mutation, there was an improvement in overall progression-free survival from 3.5 to 3.6 months. At the base, we understand that a single agent fulvestrant in the second line after the exposure of AI-CDK gives us around somewhere between 3 and 4 months. It had improved to almost 7.5 months, which is in both the subsets. And so basically a doubling of the PFS was seen with the addition of Capitello. Next line, please. If you look at the 3 mutations which are there in the AKT pathway, there's a PIK3CA alteration, there's a AKT1 alteration, and there's a PTEN alteration. The benefit was seen in all 3. However, it was more marked in the AKT and the PTEN pathway alteration rather than the PIK3CA. The delta is almost 6 months in the AKT and PTEN. It's 3 to 3.5, 4 months in the PIK3CA pathway. Again, the benefit was seen in all the 3 mutations. Can I have next slide, please? not only did it impact the PFS1, it also impacted the PFS2, in which you could see that there was an improvement in the. So, by the way, the Capitello trial had included, it included all the mutations, as in it was enrollment was not dependent on the AKT mutation, but finally it got approval for the AKT pathway mutation. But in the in the PFS2, there was an improvement seen in the PFS2 irrespective of the mutation, and patients who had PIK3CA, AKT, or PTEN mutations, the delta was significantly longer. Next slide, please. Safety, which has been a pain point for alpelisib, was obviously better, but then for us to have a practical experience of it, I think we'll probably have to wait till the third. From looking at the theory part to it, the discontinuation is somewhere around 10% with the capivasertib, as compared to we all understand that alpelisib is a difficult drug. We've all had troubles with it. So with the capivasertib. Next slide, please. Again, what we are seeing here is that there is, as I've told you, the diarrhea, nausea, rash, fatigue, vomiting. The usual culprits are the more common side effects. Hyperglycemia, which is a very painful effect with alpelisib, is somewhere in the range of 60 to 80%, with the severe hyperglycemia seen in somewhere around 2 to 3%. So I think it seems the toxicity profile of it seems significantly better. So to conclude, Capitello 291 or capivasertib with fulvestrant will possibly be the standard of care when it comes to market in India, and globally is the standard of care when it in a previously treated CDK4/6 plus AI patient pathway, and it has shown its efficacy even in the patient who have been previously treated with CDK4/6, and the overall survival benefit will have to be seen in on the further trials. So I've not made a separate slide for it, but then there are a few points which I wanted to notice here. Uh, Again, so basically, I would have liked the comparator arm to have a maintenance. The comparator arm to have a maintenance of CDK4/6 continuation to be there, because it would have probably shown what probably happens in the real world more now. I think if we do not have a PIK3CA mutation, if we do not have a AKT PIK3 alteration, we generally end up treating these patients with the continuation of CDK4/6. That's one. Second, if it was not done, then addition of everolimus possibly may have had some more effect to it. It probably would have been a more real life scenario. However, as Dr. Bhattacharya showed us, that for the patients who are PIK3CA, if they are being treated by AI and have had a primary endocrine resistance, possibly will be moving them to EMO 120 rather than going to the normal path of Mona Lisa 2 or Paloma 2. So I think that field is going to get crowded when it comes to the first line. So how much of it will be applicable to the second line, that we need to be seen. However, for most of the patients who have been treated with a standard AI CDK, a Mona Lisa 2 or a Paloma 2 or a Monarch 3, I think Capitello 291 would be the way to go. So yeah, I think I'm very really, really waiting for this drug to come to India, and we'll see how it goes from here. Thank you.
So thank you, Dr. Bhuvan. So we quickly move on to the second last talk before the professor comes in. Dr. Alok Gupta, who is the Senior Director and Head Medical Oncology at Medanta, Lucknow, is going to talk on the Ember 3 study. Dr. Alok?
Thank you, sir. Very good evening to all. Thank you for this opportunity. Can I have my slides, please? Yes. So I'll be speaking on the Ember 3 trial. So just to begin with the background. So ER and CDK4/6 contribute to ER positive and HER2 negative advanced breast cancer development. Therefore, targeting these pathways via endocrine therapy and CDK4/6 inhibition has become the mainstay of treatment. Inhibition of ER and CDK4/6 after progression on CDK4/6 and endocrine therapy may be needed for improving disease management regardless of the presence of PIK3CA and ESR1 mutations. And abemaciclib is one drug which has demonstrated activity in patients who have been previously treated with CDK4/6 inhibitor. Now, with regards to the endocrine therapy, there are other molecules which we use beyond AIs, and one of the prominent one is the fulvestrant, which is injectable. And then the other newer drug is imulin, imlunestrant, which is an oral formulation. So it is an oral SERD. So the highlight of this trial is evaluation of this drug, which is imlunestrant, slightly difficult. Yeah, so that's an oral SERD. Next slide, please. So Ember 3 trial, it randomized patients, it's a phase 3 study, and it randomized patients who were either men or women who had hormone receptor positive, HER2 negative advanced breast cancer, and those who had received at least one line of therapy for their advanced breast cancer. They also included patients who had progressed on adjuvant setting. So the patients who have been on AI and CDK4/6 inhibitor and those who have progressed on first line setting. So these were included. So it's a fairly large study, 874 patients included, and they were randomized into three groups. Group 1 received imlunestrant 400 milligram per oral once a day. The second group received imlunestrant along with abemaciclib, and the third group received the standard of care endocrine therapy, which would be an investigator choice as a second line management for hormone receptor positive advanced breast cancer. So it could be either exemestane or fulvestrant, depending upon the physician choice. The co-primary endpoint for this study was progression-free survival in the intention to treat population, and they made two comparisons here between the group A and the group C, and then there was a comparison between group B and group A. And another primary endpoint was to look specifically for patients with ESR1 mutation. So what is the PFS difference in particularly in those refractory subset? The secondary endpoint was looking at the overall survival in intention to treat population and patients with ESR1 mutation. And then there were co-secondary endpoints including response rates, duration of response, clinical benefit rate, safety profile. Next slide, please. So when we look at the primary endpoint, which was progression-free survival in these two groups, so one is intention to treat and one is the ESR1 mutated subgroup. So in the ESR1 mutated subgroup, imlunestrant appeared to be better. So PFS was 5.5 months compared to 3.8 months with the standard of care or the physician choice treatment. So which was statistically significant. And if we look at the intention to treat population, again, we find that the PFS was almost similar. So from these two curves, we can make out that particularly for patients who have ESR1 mutation, imlunestrant appears to be acting better as a second line standard of care, second line treatment compared to the standard of care management. Next Yeah, next slide, please. Yeah, can we move to the next slide? Yes. To the other endpoint, which was just go a slide back. Go a slide back. Yes. So another primary endpoint was to compare these two groups. So that is imlunestrant alone versus imlunestrant plus abemaciclib. Now you would recall that this trial included patients who have also received CDK4/6 inhibitor earlier. So abemaciclib, which appears to be an active drug even in those patients, so this was combined with imlunestrant in the group B of this trial. And when we compare these two molecules, we find that the PFS was better with the combination strategy. So imlunestrant plus abemaciclib, the PFS was 9.4 months compared to 5.5 months with imlunestrant alone. So the combination appears to be acting even better as a second line strategy. Next slide, please. Right. So, and when we look at the key subgroups, we find that this combination appears to be effective compared to single agent in across all various subgroups. So, when we look at the resistant population, the ESR1 mutation, we find median PFS with the combination is 11.1 months versus 5.5 months with imlunestrant alone. And even in patients who do not have ESR1 mutation, again, it was significant. Patients who have received CDK4/6 inhibitor. So this is important. I mean, this was very interesting. The median PFS was 9.1 months versus 3.7 months. So abemaciclib appears to be acting well in patients who have received prior CDK4/6 inhibitor when it is combined with this molecule. Next slide, please. So the conclusion from this phase 3 trial was that imlunestrant alone versus the standard of care endocrine therapy, which could be fulvestrant or exemestane. So it improved median PFS in patients who had ESR1 mutation, positive hormone receptor positive, HER2 negative advanced breast cancer. However, no significant difference was seen in intention to treat population. The second conclusion was that imlunestrant in combination with abemaciclib significantly improved progression-free survival in patients with hormone receptor positive advanced breast cancer compared to imlunestrant alone. And this combination appeared to be active in all these various subgroups, whether it was ESR1 mutated or ESR1 wild type, and even in patients who have previously been treated with CDK4/6 inhibitor. So investigators concluded that imlunestrant plus abemaciclib is a potential all oral. So highlight is that it's an oral formulation. So all oral targeted treatment option for patients with hormone receptor positive advanced breast cancer who have progressed on previous endocrine therapy. Thank you.
So thank you very much, Dr. Alok. So I'm told Dr. Rajat is not going to be able to join. So basically, so we now will request all the speakers to stay back. And now we're going to be inviting Professor USP Curigliano. Yeah, I can see him. So thank you very much for being with us, Professor Curigliano.
Pleasure for me. Thank you.
Yeah. So I think everybody knows him because he was part of the Indo-ESMO, ISMPO-ESMO joint session, which was done in Delhi a few months ago. And we have been, looking at his work and listening to his talks all across the world since he has been doing, early drug development in the field of breast cancer. And he is the chief of clinical division of early drug development at Milano, Italy. And he has several awards to his name. Just to say here that he has nearly 700 publications and 83 of which are in high index. And he is the editor-in-chief for ESMO Open. And he's the recipient of ESO Umberto Veronesi Award in 2017. So I hand it over to you, Professor Curigliano, for your talk on recent advances and treatment sequencing in HR positive, HER2 negative metastatic breast cancer post CDK4/6 inhibitors.
Thank you.
Space is getting cluttered, as we just heard. So you have a lot to tell us as to how to proceed in these patients. Thank you very much.
Thank you very much for the kind introduction. So we will discuss about advances and treatment sequencing in patients with HR positive, HER2 negative metastatic breast cancer post CDK4/6 inhibitors. Those are my disclosures. So let's start from the algorithm of ESMO. So once you have a patient with HR positive, HER2 negative, metastatic breast cancer, the treatment option should go on a first-line therapy with endocrine therapy plus CDK4/6 inhibitors. What is really important to consider is that you will use AI for endocrine sensitive disease and fulvestrant for endocrine resistant disease. Once we move in the second line setting, according to the ESMO treatment algorithm, we have a biomarker-driven approach. So you should perform NGS, and if you identify a PI3 kinase mutation or an AKT or a PTEN, of course, you may consider the use of capivasertib plus fulvestrant. If you have a PI3 kinase mutation only, you can also use alpelisib. If ESR1 mutation, elacestrant, and I believe in a few months we will see the data of SERENA-6. If a mutation of BRCA and PALB2, you can use PARP inhibitors. Consider that also for patients progressing after 1 or 2 lines of endocrine therapy, as we listened before, we have the data of DESTINY-6. So there is the option also of using trastuzumab deruxtecan. If we summarize the data in the first-line setting, you remember very well that trials with CDK4/6 inhibitors have been designed in endocrine-sensitive disease in combination with AI, MONARCH 3, PALOMA 2, and MONALEESA 2, and in endocrine-resistant disease in combination with fulvestrant, MONARCH 2, PALOMA 3, and then MONALEESA 3 and 7, even if here we have a mixed population. CDK4/6 inhibitors are a little bit different across them. We have some of them more on target on CDK4, some of them with more off-target activity, but all the trial had as a primary endpoint median PFS. And if you remember, all the trial according to the primary endpoint are positive. MONALEESA 2, PALOMA 2, and MONARCH 3 for endocrine-sensitive disease, with an improvement of median progression-free survival and the hazard ratio ranging from 0.54 for the MONARCH 3 to 0.58 for the PALOMA 2. The most important thing is that not all the trials were positive for the key secondary endpoint that was overall survival. So we have an overall survival benefit for MONALEESA 2, an overall survival benefit for MONARCH 3, even if not statistically significant, but for sure clinically meaningful, and no benefit from the PALOMA 2. When we move in the endocrine-resistant disease, MONALEESA 7, PALOMA 3, and MONARCH 2 were all positive for the primary endpoint that was the median progression-free survival. And so here we have a hazard ratio ranging from 0.46 for PALOMA 3 to 0.55 for the MONARCH 2. And in terms of survival, we have a statistically significant overall survival for MONALEESA 3 and MONARCH 2, not for PALOMA 3. Of course, what to do after CDK4/6 inhibitors? We know that we have several mechanisms of resistance. All the speakers before me clearly presented the data across all the subgroups. And you know perfectly that we have upregulation of several pathways. The most common one are PI3 kinase and AKT, but we may have also ESR1 mutation, retinoblastoma loss that may confer resistance to CDK4/6 inhibitors, and of course, upregulation of cyclin D2 and cyclin D4 that are now new potential target. Of course, several data have been produced on CDK4/6 inhibitors beyond progression to CDK4/6 inhibitors, but the two randomized trial were the Maintain trial and the Post-Monarch. In the Maintain, patients who previously received CDK4/6 inhibitors have been randomized to Ribo plus switch of endocrine therapy versus placebo in switch of endocrine therapy. The trial demonstrated a marginal benefit in terms of median PFS. The second study was the Post-Monarch. Patient progressing to previous CDK4/6 inhibitors have been randomized to Abema plus fulvestrant versus placebo fulvestrant, and there was a benefit in median PFS, also in this case a marginal benefit. ESR1 mutation is for sure an important driver of resistance. In the past, if you remember, in many studies, incidence of ESR1 mutation was tested, and if you check across studies with CDK4/6 inhibitors or mTOR inhibitors, the range of mutation is between 26% and 48%. ESR1 mutation is a very important driver, and here we have the data of the PADA-1 trial. Very interesting trial. In patients receiving AI plus CDK4/6 inhibitors, there was a serial testing of ESR1. And once ESR1 mutation was intercepted in liquid biopsy, patients have been randomized to the same treatment, AI and Palbo, versus fulvestrant and Palbo. Consider that in this trial, for all patients, there was no radiological progression. So this was really a pure study based on ESR1 mutation interception and then randomization. The trial demonstrated a median PFS benefit from 5.7 months to 11.9 months. And importantly, at ASCO this year, we will see the data of Serena-6. Serena-6 is a trial, a registration trial, in which the study design is very similar to the PADA-1, and you have a detection of ESR1 every 2-3 treatment cycle. Once detected, patients will be randomized to camizestrant plus the CDK4/6 inhibitor versus same treatment. Consider that also in this case, there is no evidence of disease progression. So, important trial, registration trial. We know that data are already available by press release. There is a positive result, and we are very curious to see the data. The only oral SERD approved up to now is elacestrant, and the activity of elacestrant was tested in a prospective randomized trial, including patients that received CDK4/6 inhibitors, because in the Emerald trial, all patients received CDK4/6 inhibitors, and patients have been randomized to elacestrant versus investigator choice treatment. Co-primary endpoint were median PFS in all patients and in ESR1 mutant patients. The trial demonstrated an improvement in median progression-free survival in both intent to treat and the ESR1 mutant population, but you know that the label actually is only for ESR1 mutant population. And when we check the patient population who derive more benefit from elacestrant, we will discover that are patients with ESR1 mutation who received the previous exposure of CDK4/6 inhibitor for 1 year or more. In this patient population, median PFS was improved from 2 months to 8 months. Of course, oral SERD are under development. Camizestrant is one of these, and in a previous phase 1/2 study demonstrated an improvement in median PFS, but we will see the data in the Serena-6. Other option, of course, in the post-CDK4/6 inhibitors is everolimus, even if we don't have data after CDK4/6 inhibitors. And of course, alpelisib, since the SOLAR-1 trial tested the activity of this alpha-selective PI3 kinase inhibitor, but in a patient population who never received the CDK4/6 inhibitor with an improvement of median PFS, no improvement of overall survival. That's why the BioLive trial was designed in the post-CDK4/6 inhibitor setting with a single-arm trial demonstrating 7 months of median PFS. We already listened to the data of INAVO 120 with capivasertib, and we have another trial with a PI3 kinase inhibitor in the front line, that is the INAVO 120. This is a trial, of course, that tested the activity of INAVO, palbo, and fulvestrant in the first-line setting, only for patients with the PI3 kinase mutation, and very few of them received the adjuvant CDK4/6 inhibitor. The trial, in my opinion, was impressive in terms of improvement of median PFS. We know that Dr. Komal Javeri will present data also on overall survival during ASCO this year, and it was anticipated by a press release a positivity. The other trial using a PI3 kinase, AKT, and PTEN altered pathway targeted agent was the Capitello 291. Data have been presented. If you remember, the primary endpoint was PFS in all population and in the AKT altered pathway, but the label that we have actually also is only for AKT altered pathway. The trial demonstrated an improvement in median progression-free survival in both overall population and AKT altered pathway. In my opinion, this is a treatment option to be considered because personally, I believe improvement of median PFS in this setting is quite uncommon. Don't forget that post-CDK4/6 inhibitors, if you have a germinal alteration, you can consider for BRCA mutant both olaparib or Embraca, talazoparib, because we have also in this setting an improvement of median PFS. Finally, I would like to remember the Ember 3 that was already presented. This is a very strange trial because you have comparison of imlunestrant versus standard of care, and it is very similar to the Emerald, but then you compare imlunestrant, that is not a standard treatment, versus imlunestrant plus abema. And there is an improvement in median progression-free survival in ESR1 mutant population, no difference in the overall population. So the drug, if approved, will be approved only in ESR1 mutant population. But the most important thing is that you have more benefit if you combine with abema. Of course, many patients in the Ember 3 never received, of course, a previous CDK4/6 inhibitors. We move then to the novel wave of ADCs. Of course, I will mention first trastuzumab deruxtecan. TDX was previously tested in HR-positive, HER2-negative disease in the context of the DESTINY-Breast04, in which patients received 1 or 2 lines of chemotherapy. There was an improvement in overall survival in this patient population. A confirmed improvement in median progression-free survival also in the patient population that had a longer follow-up. And of course, we don't have to forget that we need also to manage adverse events, including hematological gastrointestinal toxicity and ILD. And then we presented the DESTINY-6, in which the idea was to test activity of TDX in patients who never received chemotherapy, exactly post-CDK4/6 inhibitors and post-endocrine therapy. The trial randomized patients to trastuzumab deruxtecan versus investigator choice, and we included both HER2 low and HER2 ultra low population. 152 patients were HER2 ultra low. And when I presented the data the first time, you have to consider that already some patients, 21%, did the crossover to TDX in the control arm. The trial demonstrated a benefit in median progression-free survival with an hazard ratio of 0.62 and an improvement of median PFS from 8 months to 13 months. There was also a trend for overall survival, but we will never see the data of overall survival because, as I said, all patients in the control arm will do a crossover to TDX. In an exploratory analysis in HER2 ultra-low, there was a benefit also in median PFS and overall survival, and all the subgroups derived a benefit from TDX, independently of age, immunohistochemical 1+ and 2+, number of prior line of endocrine therapy. Remember that response rate was 57% in intent to treat population and 61% in HER2 ultra-low. And safety profile was very similar to the previous one. In my opinion, TDX should be considered a new treatment option after CDK4/6 inhibitors. So after 1 or 2 lines of chemotherapy, of endocrine therapy, if you have HER2 and ultra-low disease, you have the option to consider as an alternative to chemotherapy trastuzumab deruxtecan. In my opinion, TDX should be the first option in visceral dominant disease because finally, it's clearly superior to chemotherapy, both in terms of median PFS and burden of disease. Other agents, of course, explored the activity in HR-positive diseases, such as trastuzumab govitecan in the TROPiCS-02. In later line of treatment, you have a benefit in median PFS and overall survival. And the TROPION-Breast01 also demonstrated activity of datopotamab deruxtecan, that is the other anti-TROP2 ADC explored in HR-positive HER2-negative disease with an improvement of median progression-free survival. Unfortunately, no improvement in overall survival, because we know that also in this study, many patients in the standard of care received later trastuzumab deruxtecan. So which will be the future? Of course, we have other ADC under investigation. One is sacituzumab govitecan in early line of treatment in the ASIAN-7, and the other one is the TroFuse-010 for PD-L1 negative HR-positive disease, that is sacituzumab tirumotecan. The main question is how to sequence ADC. Now we have several approved. We know from preliminary data that ADC1 has a longer median PFS respect to ADC2. Here we have sequence of saci-govitecan and TDX, or TDX and sacituzumab govitecan. But overall, in the post-CDK4/6 inhibitor setting, after you approach the patient with a biomarker-driven approach, for sure, as an alternative to chemotherapy in patients with visceral dominant disease, in my opinion, we should consider eventually trastuzumab deruxtecan. So thank you very much indeed, and I will be very happy to take questions in the discussion session.
So thank you very much, Professor Corigliano, for this wonderful, concise and enlightening talk. And certainly, I think we as oncologists are learning now that there are so many options for these patients who are HR positive and HER2 negative in the metastatic breast cancer setting. So I'm sure there are going to be questions. I hope all the speakers are there. So, to set the ball rolling, let me ask you this question that you have the current first-line therapy for these patients who have metastatic breast cancer revolves around using CDK4/6 and aromatase inhibitor in the postmenopausal setting. So a patient doing well for 3.5 years and then has a low tempo of recurrence and is judged ESR1 positive on the liquid biopsy. So what is the option here for such a patient?
After CDK4/6 inhibitor, if you have an ESR1 mutation, you should consider, you can consider, of course, the use of elacestrant because we have one drug approved. Of course, as you know perfectly, ESR1 mutation is more common in patients in later line of treatment. It's quite uncommon in endocrine sensitive disease. In terms of activity, you don't have a huge activity when you discuss about response rate, but the median PFS benefit, in my opinion, in this setting is considerable. Also, looking at the profile of safety of this drug that is very well tolerated. Of course, we will see the data of SERENA-6 because here the question will be what we are going to do when we will see the data of SERENA-6, because we need to do a serial testing for ESR1, and once ESR1 mutation is detected, we eventually should consider to switch to camizestrant. Of course, this is a new strategy. The SERENA-6 is a mindset-changing trial, not only a practice-changing trial, because we are going to switch treatment according to molecular disease rather than according to radiological progression.
So thank you. So I think I see Dr. Bhuvan Chug from Max raising his hand.
Thank you for the opportunity to ask question. I just had two questions. For somebody with a secondary endocrine resistance, let's say anything beyond 2 years on adjuvant AI, do you qualify the burden of disease, or you move all of them to Paloma 3, Manolesa 3, or Monarch 2? So what I'm asking is, if Aditya Vardia had presented the pace of progression data in SABCS 2024. So what I'm coming from is that somebody, let's say, has a heavy burden of disease, 3 years on adjuvant AI or 4 years on adjuvant AI. Would you be inclined towards moving them to an ADC or a chemotherapy rather than going them to the Mona Lisa 3 or Paloma 3? That's question number one. And also, I wanted to understand your experience on triple negative TDXT in the. So I understand that SG is the Trodelvy becomes a natural choice for the triple negative ADC. But what's your experience with triple negative ADC in terms of HER2 as first, and then obviously we talk about sequencing later, but the ADC being HER2. These are the two questions I had.
No, thank you. You correctly stated that Aditya Bardia presented very nice data in the Destiny 6 in San Antonio, in which when you have a rapid progression to CDK4/6 inhibitors, the improvement of median PFS derived from trastuzumab deruxtecan is close to 14 months. So even if I have a bias because I was one of the PI of the study, I believe for this patient population, you should consider the use of the ADC. I completely agree with you because the benefit of the ADC is much more than any other chemotherapy. Regarding the second question, TDXD in the Destiny 4 has been tested also in a small cohort of patients with triple negative HER2-low disease, and they were 54 patients, and there was an improvement in both median PFS and overall survival. But usually, of course, when I have a triple negative breast cancer, I prefer to use first sacituzumab because we have evidence from a prospective randomized trial, of course, targeting only the population of triple negative disease, and eventually to use later TDX, even if in some patients who relapsed earlier to neoadjuvant adjuvant immunocheckpoint inhibitors, in this patient population, if they're too low, I used trastuzumab deruxtecan with an excellent activity. So TDX is a very good agent also for triple negative HER2-low disease.
Thank you.
Thank you, Professor. Dr. Ghansham Biswas from Bhubaneswar.
So good evening all, and thank you, Professor, for that exposition. So we have a patient who has progressed on CDK4/6 first line, Now, in a resource setting, so this patient is a HER2 0, BRCA negative, PIK3 negative, androgen receptor negative, and somehow I have done a PDL1, which is positive. So in this setting, so we haven't done an ESR1 or an AKT. So can you consider anything on the horizon for this patient, like a triple negative IO-based treatment?
Yes, we are doing a study on this patient population. We have some patients in our setting that from HR positive became in the metastatic setting or after progression to CDK4/6 inhibitors HR negative. What I do in my practice, if on the biopsy this is a triple negative disease and it is PD-L1 positive, of course, I consider to use chemotherapy plus immunocheckpoint inhibitors. Maybe in the future we will have more molecular imaging. Now there is the FAST in which you can localize estrogen receptor expression with a PET scan, but we don't use this in clinical practice. So in a patient like the one you presented, and I had some in my clinical practice, I used chemotherapy plus immunocheckpoint.
Thank you so much. Thank you.
I saw that there is an interesting question in the chat. It's a patient with both ESR1 and PI3 kinase mutation. I believe this is an interesting question. Usually, if you have both mutation, if you have to remember that Aditya Bardia presented a subgroup analysis in the Emerald in the patient population with both mutation, ESR1 and PI3 kinase. And in that scenario, activity of elacestrant was very limited. So to be honest, in a patient with ESR1 and a PI3 kinase mutation, I would prefer to use a combination therapy and not a monotherapy. So my option would go to fulvestrant plus capivasertib and not elacestrant alone. Yes.
Do you think that's also because there's a downstream PIK3CA involvement in a ER, as in the ER shall anyway act through the PIK3CA downstream? Is it something to do with that? And that's the reason you think the assistant doesn't work much in that?
Yes, because we have some preclinical data from Baselga, if you remember, in which downregulation of estrogen receptor pathway with fulvestrant may upregulate the PI3 kinase pathway. So biologically, this may happen, and I agree perfectly with your comment.
Yeah, Dr. Ajay Bapna from Jaipur.
Yeah, Dr. Kurugilianu, I just want to know that in endocrine resistant disease progressing on CDK4/6, suppose it has progressed less than 6 months. So do we need to consider the initial biopsy, or you need to repeat biopsy within 6 months? And part 2 of the question is, if there is only bone metastasis, do we do the bone biopsy for the ERPR and HER2/neu, and what is the correct method of doing HER2/neu?
But, usually I don't. If they progress within 6 months, and I did the biopsy before starting CDK4/6 inhibitors, assuming that I did before starting CDK4/6 inhibitors, usually I don't perform a new biopsy, and I would go in this patient population directly to an ADC, and specifically trastuzumab deruxtecan.
And bone metastasis, how do you assess the HER2/neu if you have to do only the bone biopsy?
It's a difficult question, this, because you know that using testing HER2 in bone disease is not so easy. In the Destiny 6, there were very few patients with bone-only disease, only 3% of them. And it was mandatory to reevaluate HER2 status on the primary tumor because cannot be used in the study, the bone biopsy, to determine the level of HER2. Very good point, the ones that you raised.
Yeah, thank you.
So Professor, it seems that you're going to TDXD for virtually all patients after CDK4/6 failure. So who are the patients whom you would not use TDXD after CDK4/6,
I know.
fails?
Thank you for your question. What I said is that if you have a dominant visceral disease, I would prefer to use trastuzumab deruxtecan because response rate is more than chemotherapy, median PFS is better, and potentially, of course, there is an overall survival benefit. I would consider another approach for those patients with a long history of previous exposure to CDK4/6 inhibitors, so highly endocrine sensitive disease with asymptomatic disease and predominantly bone disease. So this is the patient population in which eventually I would consider to use only capecitabine rather than moving directly to TDX.
Okay, Chandrakant, you want to ask any question, or I think, or you want to take over?
So just last question, sir. So we have so many options now, the clinical trials are so many. So once patient has progressed on hormonal therapy, you have TDXT, you have Dato-DXT, you have Sacituzumab. So how to choose one over the above in this scenario?
Yes, sequencing is the main question for the future. So you raised really the perfect point. So I would use the ADC according to the evidence of the clinical trials. So if you have HER2 low and ultra low, the only drug tested after CDK without any chemotherapy is trastuzumab deruxtecan. So my first option will go for TDX. Then in later line, of course, you have both sacituzumab govitecan and datopotamab deruxtecan, but since the payload of datopotamab is the same of trastuzumab deruxtecan, in that case, if you progress to TDX, I would consider sacituzumab and not datopotamab deruxtecan. Of course, we need also to see the data of ASIAN-7 that will be available, I believe, in San Antonio this year, because ASIAN-7 is testing activity of sacituzumab in patients who never received chemotherapy. So we will see the performance of Sachi in this patient population.
Right. Thanks, sir, for that answer. So one more question is, if we have, should we test all these markers in a treatment-naive metastatic disease, or should we reserve testing all these for a subsequent line therapy, like the ESR1, PIK3CA, AKT-mTOR, BRCA, all these I'm just asking you.
But in the clinical trials testing activity of elacestrant, there were also some patients who received the previous chemotherapy, of course. So you can do the testing also in later lines after chemo. In my practice and in my country, since there is a national health system, the only window to give this biological agent is after CDK4/6 inhibitors. So we cannot use those drugs in later lines. So what we do after progression to CDK, we do the biomarker testing and we try to maximize the use of this biological agent before moving to a chemo regimen or an ADC regimen.
Okay, I think, Professor, I think that was wonderful. You really answered all the questions to our satisfaction, I would say, and perfection. So I think now I hand it over to Dr. M.V. Chandrakant for conducting the next part of the program, which is based on the case discussions. Over to you, Chandrakant.
Thank you so much, sir, for that introduction. And it is a pleasure to be in front of you all and to hear Professor. So, to have a couple of case-based discussions so that, we have an idea as to how to take these data into clinical practice, I would first request Dr. Mohanty. He is a consultant medical oncologist from HCG Cancer Center, Cuttack. Dr. Sri Gopal, over to you, and you can continue with the case presentation. It's a very interesting case, it's going to get into your brain. So after that, we can have a panel discussion. Dr. Sri Gopal, over to you.
Thank you, sir. Thank you. Good evening, everyone. Yeah. So can I have my slide, please? Yeah. Good evening, respected seniors and friends. So I'll be taking you all through a case of hormone receptor positive and HER2 negative metastatic breast cancer. So next slide, please. So it's our own case. A 38-year female who was diagnosed as a case of carcinoma right breast in October 2021. It was IDC grade 2. She underwent left MRM on date 29th October 2021. Post-op histopathology, it was PT2N2, 5 of 18 lymph nodes was positive, ERPR strong positive, HER2 1+. She received adjuvant chemotherapy, 6-cycle FEC without any taxane. It was given by surgical oncologist at outside center. So completed in March 2022. Subsequently, she received adjuvant RT40 grain 15 fraction, completed in April 2022. So then she received tamoxifen for 11 months. So after 11 months of tamoxifen, so next slide, please. So after 11 months of tamoxifen, she came with complaint of severe back pain. And on PET-CT evaluation, which showed extensive skeletal mets involving both axial appendicular skeletons, and there was spinal cord compression at D12 and L1 level. After which she received palliative EBRT 30 grade N fraction, last dose in May of 2023. Subsequently, she underwent bilateral surgical oophorectomy on May 2023. Then there was a gap of about 2 months. Then subsequent PET-CT, which showed a new mediastinal and retroperitoneal nodal mets. Then she was started on palbociclib plus letrozole plus zoledronic acid. So next slide, please. After use of palbociclib, letrozole, zoledronic for 4 months, again she had progression of symptoms. She again came back with severe upper back pain and pain abdomen. So next PET-CT on October 2023, it showed skeletal disease progression with 2 new liver nodules and lung nodules. Thus, in view of the visceral disease, we repeated the biopsy, which showed again the metastatic ductal carcinoma. It was URPR again strong positive and HER2 was 1+, the same as before. Then she received palliative EBRT to cervical and upper dorsal spine because of the symptomatic site and some cord compression. Then after, she was started on abemaciclib plus fulvestrant plus zoledronic acid. So before the post-monarch data came, so we just tried to have this drug because the patient was also not affordable for other like TDXT also. So patient was symptom like free for almost 6 months. So after 6 months of abemaciclib fulvestrant zoledronic acid, so in May 2024, again, she developed back pain, cough, pain abdomen. So next PET-CT done in May 2024, they saw that reappearance of lung and liver nodule and skeletal cell disease progression. Next, please. After this, some molecular evaluation we did, and PIK3 was negative, MSI stable, germline BRCA2 was found pathogenic. Then she was also, of course, not affordable for TDXT at that time, so was started on olaparib 600 mg per day. After 2 weeks of evaluation, she came with severe fatigue, anemia, hemoglobin was 5 gram%. So after PRBC transfusion, the dose of olaparib was reduced to 450 mg per day with zoledronic acid 3 monthly. Patient now is doing well on 11th months of follow-up. She is on olaparib 450 mg daily with zoledronic acid 3 monthly. Recent PET-CT done in February 2025 showing a partial favorable response with healed lung and liver lesions, regression of skeletal disease. Now, being a engineer in profession, both the wife and husbands, they are concerned about the subsequent line of therapy on progression. Of course, she is not very economically affordable, so some sort of cost-effective treatment she is looking for. So now I would like to hand over the session to our beloved Chandrakant sir to take us forward further with the discussion. Thank you everyone.
Thank you, Dr. Sri Gopal, for that wonderful case presentation. Let me just share the same slides which you presented. Hope I think it's visible. Right. So I would have all the panelists on stage. I will request Gansham sir, Dr. Gansham Bishas, Dr. Rajat Bajaj, Dr. Pankaj, and Dr. Ajay. So all of you can actually participate. So we don't have Dr. Sushant and Dr. Gaurav. So, Ghansham sir,
Yes.
let me start with you. So, would you have treated this patient differently? Let's start from this
Yeah.
tamoxifen
Right. So
progression.
first of all,
Right.
yeah. So as Sri Gopal presented, since this was treated, systemic part was also treated by surgical oncologists. So we missed on taxanes, right? Second, she is a 38 years old lady. So I would have done upfront BRCA for young lady, and definitely I would have treated her differently. At least in 2021, I would have gone for an ovarian suppression and put them on exemestane at least. And in 2025, definitely, so she would have been a candidate for monarchy. So that's the first part. Second part, so once this patient has come with the progression, so however inadequate treatment at the first front, so definitely, palbo letrozole would have done, and again, so would have done at least the PIK3 and the BRCA, because so young patients, even with the ER/PR positive, HER2 negative, so we expect at least 12% of these patients will have BRCA mutations. And on progression, so this patient was switched over from palbo after 4 months to Abima and fulvestrant. So what I do, so if such things happens to my patient, so I would have continued palbo and just switch over from letrozole to fulvestrant, and then probably would have continued. And the last part was, if this patient is doing good on olaparib, and now suppose this patient progresses, so definitely we have TDXD, and now the PAP is also there 1+1. If she's not affording for that, since she is a BRCA positive, at least I can consider her for some platinum-based therapy with the taxanes which she's not exposed to, and being BRCA positive, I will bring into carboplatin. So I will treat her with weekly Pacli, Nab-Pacli, and then maybe a 3-week carbo. So that's my take, Chandrakant.
Great, sir. Great. I think fantastic. I think we all concur with what you have said. Well, directly, if I can ask Professor if he's available, Dr. Curigiliano, do we have him?
No, sir. Professor Quigilano has left the
Right,
meeting.
right. No worries. So, if he's not there, I'll go to Dr. Rajat. Dr. Rajat, I will specifically ask you here, right? Post 4 months letro patient has got a liver biopsy, with 1+ HER2 positive. So, Dr. Rajat, what would you do? This is not an endocrine disease. This patient has progressed on letrozole here. What would you have done in the present day today if the patient comes to you? 4 months of hormone therapy in metastatic setting. What would you have done? HER2 low.
Yeah, so I think first of all, I'd like to say that uh, Bishwas sir has actually summarized it very well. I think there is no scope after what he's spoken.
Right.
It is like totally summarized it absolutely well. So now you're asking me as to what will we be doing in 2025. So we have the TDXD data now with low HER2 and with one line of therapy of hormone, and that too when the hormone has not worked, the resistance of the hormone is there. So I would like to go what for TDXD. Having said that, with all of these patients, I make it a point
And
to
also
check for.
BRCA positive. And also BRCA
Yeah.
positive.
Yeah, so okay, I thought that you are giving me a scenario where BRCA positivity was
No,
not known.
no,
So,
it's not
so I
2025. You will test, no?
yeah. So certainly, like I said, that if it is 4 months that the patient is progressing, I would certainly like to check for BRCA if at all it has not been tested previously, and also look for PIK3 and CCND1 amplification. These are the three most important reasons for a CDK4/6 not, I mean, a failure of CDK4/6. So if the BRCA is positive, I would like to use olaparib and reserve TDXT for a later date. And if it is negative, then TDXD is an option if the patient can afford.
Right. So in the present day, from what we understood is we will do a BRCA testing, PIK3CA, all these ESR1, all these resistance mechanism testing. And if it is BRCA positive, we will position olaparib right now and then we will reserve TDXT for subsequent line. And that is how we will look into. So Dr. Ajay,
Yeah.
sir, would you, I mean, is that the way I think we can do in the
Yeah,
present
I
day?
think I have certain points to make. The part which was managed by the medical oncologist was perfect. And if you look at the exploratory analysis of post-monarch, it very well covered the endocrine resistant disease. It covered the PIK3CA mutation disease. It also covered the ESR1. The benefit was seen in all these three groups. So the decision of abemaciclib and pulvestrant with zoledronic acid was absolutely right. And as far as the further treatment is concerned, it will be definitely based on the biomarkers, which we will do to know the exact resistant mechanism. Regarding use of trastuzumab deruxtecan, DB06 is still, the regulatory approval is still pending. Though we have regulatory approval for DB04, where one-line chemotherapy is allowed. So the use of TDXD is absolutely out of question even in 2025 till we have regulatory approval. So far, I am totally convinced the way this case was managed, and post monarch, we can use the drug as per the findings of the resistant mechanism.
Right. So Professor just mentioned, we were just asking him a question like, if there is visceral progression, like this patient had liver progression, no, with a very short time on hormonal therapy. If that is so, he was like, I would prefer a ADC over a hormonal therapy. So that was the reason why I think I was just asking
So
repeatedly.
the treating physician need to clearly understand whether it is a visceral disease or visceral crisis.
Right. Right, sir. So I think what we can understand, I think Shri Gopal really treated the patient well. So what we
Yeah,
can
he has.
understand is, yeah. So post CDK failure, okay. So if there is gross visceral progression, that to a primary endocrine resistant and is not responding to hormones, instead of hanging on the hormonal therapy, try and switch to ADCs quickly. This was BRCA positive, therefore olaparib was did really well. If it's BRCA negative, then quickly we should have given TDXT in the space, and it should be preferred over other chemotherapy options. I think that is what is Destiny 06. I think that is the
Yes.
main criteria. Chemo naive patient, hormone not the responsive post CDK4, and rapid visceral progression, and that is a patient where you would fit into Destiny Breast 06. I think that is one
Instead
thing.
of the conventional chemotherapy, might as well use the TDXD.
Right. So that is the one thing. And this patient had BRCA, therefore olaparib really did well for this patient.
And
So
I think I
yeah,
like to add that always look for BRCA and PIK3 at least before looking for a TDXD, because if these two are there, then TDXD probably would be the next line, and one would move for the targeted therapy in the subsequent line.
right, right. So Dr. Pankaj, just to take your opinion, so what are the biomarkers you would do in a metastatic ER positive breast cancer in the present day?
So I think I agree that we have to go for something like which includes all these markers ESR1, then PIK3. So these had to be seen and along with BRCA to decide the further lines of treatment.
Right, right. So it is nothing like becoming a lung, where you need to do an
Yeah,
NGS.
actually, yeah, something like
So
that.
ESR1, HER2 low, HER2 ultra low,
Yeah,
PIK3CA, AKT, mTOR, BRCA, and
yeah,
you will get much more, in future. So more mutations, more drugs, more confusion as far as sequencing is concerned.
yeah.
Right. I think we had a reasonably well, a good panel discussion of the first case. If nobody has anything to say for the first case, let us quickly go to the second case. I would request Dr. Ankur Punia, who is an assistant professor from Sri Ram Cancer Center, Mahatma Gandhi Medical College and Hospital, Jaipur. Sir, I have shared the slides. You say next, I keep moving them.
Yeah, thank you, sir. Thank you for the introduction. So,
Right. So
so
the panelists, I think I think we have Dr. Vivek also. He has just joined. So yeah, this is the case.
So next slide, please. So this is a basic case of a metastatic breast cancer patient, a 46-year premenopausal woman, diagnosed with bone mets in the baseline, had a breast mass, ERPR done positive, HER2 new 1 plus, Ki67 on the lower side, 15 to 20%. So premenopausal 46-year-old metastatic breast cancer patient. Next slide. So she was started at the standard treatment of palbociclib with letrozole with the denosumab. Leuprolide was also given to the patient. It was not mentioned here by mistake. Patient was started on that. Patient developed some bleedings for which she underwent THBSO, eventually found to have some deposits in the uterus and ovary as well. But patient responded to the treatment. Patient continued the same treatment for almost 37, 38 months and tolerated the treatment well. Eventually, she started to have a progression. Next slide. So this is what happened. In November 29, patient progressed, and at that time the NGS was done on the progression on the new disease. And as common scenario, ESR1 and a PIK3C mutation was seen. So what next to be done for this patient? So what's best possible next was done. Next slide. So patient was started on fulvestrant along with alpelisib. Initially, patient had a troublesome initial few weeks because of hyperglycemia, which happens in majority of the patient, I say. And if they, develop, if they go crosses the 4 week mark, then next time and then beyond that is pretty much easier to tolerate. So patient had a modified dose, but she tolerated and completed and had a response. So almost for 2 years, the patient took alpelisib and then eventually had a progression. Next slide. So patient presented with pancytopenia, bone marrow done, showed infiltration by the disease, showed again ERPR positivity, HER2 1 plus, Ki67 was on the higher side, 40%. MRI done also showed a pachymeningeal enhancement. So patient had a leptomeningeal disease as well as bone mets and had a liver mets. So patient had a low count, cytopenias, multiple blood transfusion. So what next for this patient? Next slide. So patient was started at that time. We didn't have any other option. So started on some low dose epirubicin given weekly. Patient initially had some response, had a stable disease for around 4 to 6 months. Then patient went into remission, became transfusion free, but again started to have, disease started increasing. Then switched to again nab-paclitaxel. Patient developed neuropathy, and eventually patient progressed after 4 months. Next slide. Progress again with multiple liver mets, bone mets, peritoneal disease as well. So patient has taken 4 lines of treatment, almost 6 years. And so what is the next best option for these patients? Probably a few years back, again, some of other chemotherapy, but he had the now TDXT. So patient was since HER2 1 plus, patient was given the option of TDXT. And initially patient had a response. Patient responded for around 8 to 9 months. Then eventually the patient progressed and passed away. So this is the basic, what a journey of the patient, starting from the hormone therapy, chemo, and eventually targeted therapy. So over to you, sir.
Thank you, Dr. Ankur. Very interesting case, and you have treated the patient extremely well. So, well, I will request Dr. Vivek to pitch in. Dr. Vivek, so I think you looked into the case history. So, in 2025, how you would have treated the patient differently? At which point you would have actually changed?
Yeah, I think, as compared to the earlier case where, there was a surgical oncologist who had treated the patient, here because a medical oncologist was treating the patient, there is hardly any scope for, changing the treatment or managing differently. However, because the TDXD was used in a fifth line, and we could clearly make out that yes, when TDXD was used, there was a much better response as compared to the previous chemotherapy regimens. So currently, as per the data in ER positive breast cancer, after a single line of chemotherapy, we can use TDXD. So I think post the anthracycline, single agent epirubicin that he used, probably we could have bought TDXD in the earlier lines. I think this is one of the messages or changes that probably could have changed the course of the disease. We know how powerful the drug TDXD is. Secondly, I think there is still some scope for evaluation of the patient from an NGS point of view regarding what are the different mutations and whether an ESR1 mutation was there or not.
This one.
And yeah, and there are newer treatment agents like an oral SERD.
Oral SERD,
That
right?
Yeah, and
Capivasertib is
correct.
also there in
So,
the PIK3CA
with
space, right?
PIK3CA, there is option of capivasertib. There is an option of, just as Dr. Ajay was mentioning regarding post monarch. In the last SABCS, there was even data for use of olaparib. There was olaparib. There was use of abemaciclib with other oral SERDs like
Right.
like elacestrant. So these are, sort of newer coming data. There is also a newer PIK3CA inhibitor like inavolisib, which has much less toxicity, and that can also be combined with an oral SERD.
Right.
So these newer combinations, and then the top-2 agents like datopotamab deruxtecan. So these newer agents, all this data is coming, and we are realizing that probably chemotherapy is not the best way to treat ER-positive breast cancer, because you can get short PFS, but you cannot get long PFS or long disease control in ER-positive breast cancer. So these are the newer strategies that probably we can use right now. But all these requires a lot of logistic issues are needed, and I think we can always externally comment what could have been done better or what could have been more done. But I'm sure what the treating medical oncologist has done is probably the best that could have been achieved with the patient.
Right, fantastic points, Vivek. So, two things, what we noticed in the present day, if this is the stage where you would have pitched in, or in the present day with the data, we could have used, if we had access to oral SERDs, we could have used an oral SERD with a capivasertib. That is one, instead of fulvestrant plus alpelisib. I mean, we don't have a head-to-head comparison, but it looks like oral SERD plus capivasertib probably is better, number one. And number two is, as there was already, pachymeningeal enhancement and all, we would have tried and pitched in TDXT earlier. I think these are the two things that we could have done in the present day in a, different way. Right. So, Dr. Vivek, one more to follow up question for you. So, ER/PR positive, HER2 negative in the baseline. Let's say this patient had HER2 negative, score, because we don't look into HER2 ultra low, like 4 years before. So, in the present day, if a ER/PR positive HER2 zero has progressed post hormonal therapy, right? Do you go back and recheck your biopsy blocks, or do you do a rebiopsy to look for the HER2 ultra low status? Because at that time pathologists didn't realize ultra low is also there. What do you think about repeating a
Yeah, I
biopsy
think it's a
or
very,
doing
I
a
think,
biopsy?
Chandrakant, I think this is a very, very valid point. Now, in the management of ER positive breast cancer, the current norm is actually repeated biopsies in order to, check the ER/PR HER2 status, as well as the, different mutations. So this is the current norm actually, but because of the logistic issues, we are unable to do. Now, regarding the HER2 low and HER2 ultra low, as so far as the biopsy goes, I wouldn't really check on the old biopsy, but I would prefer to, sort of do a fresh biopsy in order to see whether it is a HER2 low or ultra low. The other day, I was having a discussion with our pathologist who had gone for a workshop on so diagnosing HER2 low, and I was telling him that now a HER2 zero report is not acceptable, and you have to report whether it is HER2 ultra low or not, and that is probably the way we all medical oncologists should go in discussing with their respective pathologists, that in the current norm, especially in metastatic cases, reporting HER2 zero is probably not adequate, and they should mention that whether it is HER2 ultra low or not, because you have the Destiny Breast 06 data now, and there is significant improvement in the outcomes with the use of TDXD, even in the HER2 low subset, ultra low subset. So this becomes really important.
Right, right. Thank you,
So,
Dr.
Dr.
Vivek.
Chandrakant,
Right,
in SABC
right.
2024, there was a very important, presentation on repeating the biopsy every time the recurrence occur because there is a change in the intrinsic subtype.
Right,
So it makes sense to repeat biopsy on every recurrence.
right, sir. So just to, you are right, sir. We need to do a biopsy now because it's a changing
Yeah.
every time it changes. So, sir, in the present day, HER2 ultra low is also important, right?
Yeah.
What percentage of ER positive patients are HER2 zero, you feel, in the present day? Zero, no HER2 at all. Like
Um,
20%, 30%?
yeah, nearly.
So that means
Yes,
70 to
sir. So
80%.
it is nearly 25%. Yeah, it is
Right.
nearly only 25%.
So that means 80% of your ER positive patients are eligible for TDXT before chemotherapy. That is the take home message.
Yes, absolutely.
So that is something really significant. So I can ask, we have Dr. Gansham, who is there? Sir, you're there?
Yes.
Sir, you would have used TDXT in the present day. Like, what percentage are HER2 positive, what percentage are HER2 low in your clinical practice in the present day?
So as of now, I've used most of my patients are in HER2 low, in fact.
HER2 low, that is
Because
the key, sir. Yes.
because the problem is that in HER2 low, we have less options.
Yes.
So beyond CDK4/6, and many of the physicians, even you see Novartis people don't promote alpelisib. So you are almost taking alpelisib out of the box.
Right, right,
If
right,
if somebody already exposed to letrozole, so you don't have an options beyond
right,
CDK4/6 and fulvestrant. So straight away you go to CDK4. So I think so that's the reason that TDXD will be in a HER2 low setting will be more than the HER2 positive.
right, sir. Right, sir. How has been your experience in the HER2 low setting with TDXT?
It's absolutely fine. So when probably I did not have much options and they have done so
You have
HER2.
a PFS of 6 months, around 6 to 8 months, like.
Yes,
Oh, right,
absolutely.
right. I think that's
Yeah.
very important point.
Chandrakant, just
Yeah,
one thing.
right.
Chandrakant, just one question I want to clear from people in the panel, that in case of a chemo naive patient, would you want to use one line of chemotherapy before you go to TDXD, or you want to go ahead straight ahead to TDXD?
I think we have data in the chemo naive patient.
Yeah, that is what I'm asking.
Destiny
That
Breast 06. Likith, you
yeah.
want to say that, Dr. Likith?
So the
He's not.
Vivek actually,
Yeah.
so in reality, so many a times, so before this PAB, so we usually start on some either maybe on weekly paclitaxel till the finances are arranged. Otherwise, if somebody is affording, so definitely we'll start that. Otherwise, in practice, many of these patients will go for a weekly, maybe for a few weeks before they have arranged it. So I think so that's the practical, and that these patients don't have a much PFS with chemotherapy by the time you land up in toxicities. So if somebody is ineligible, so I think so we'll straight away go to a TDXD.
So now there is a phase 3 data of using aromatase inhibitor and capecitabine instead of aromatase inhibitor and CDK4/6 inhibitor, a trial called MECA, which was published in JCO. So that is also very promising if you add aromatase inhibitor with capecitabine in the first line. So what is the views of other panelists?
I think, sir, there was a study called Pearl that showed that in patients who had progressed post hormonal therapy, giving single agent capecitabine also worked really well for them as compared to second line of treatment. So post the Pearl study, this MECA study showing that combination is working better, we
Yeah.
have already adopted this, and I can
Oh, really?
remember some of the patients where we are already using the combination of capecitabine plus hormonal therapy. If they are post letrozole, we have even combined it with fulvestrant also, and if they have been using some other post tamoxifen, then we have combined it with letrozole. And I have felt that this is really useful for the category of patients where the ERPR is not very strongly positive, somewhere like a ER4 positive, 5 positive, PR negative, or not those kind of patients who are strongly ERPR positive, HER2 negative, but rather those patients who are a weak ER positive, PR positive. This is my
Right,
my
right, right,
take, sir.
right, right.
Sir,
So,
sir, can I have a question?
yeah, Shivu.
Sir, just a doubt that how is your practice like? How is your experience with how to low subgroup, this TDXT? So, what do you find HR positive versus HR negative? So, in how to low HR positive versus HR negative, what is your experience with TDXT? So, is there any difference in efficacy?
Right, right. So, let's answer both the questions. Dr. Vivek was asking a very pertinent question, like endocrine positive patient, ER positive patient, post endocrine therapy, chemo naive. Should we give chemo or should we give TDXT? This is addressed in Destiny Breast 06. This is the exact inclusion criteria of Destiny Breast 06, where patients were HR positive post endocrine therapy, 2 lines, and they were chemo naive. Whether to give TDXT or chemotherapy, TDXT is a clear winner. So, Destiny Breast 06 says that position TDXT before any chemotherapy. This is in HER2 low and HER2 ultra low subset. This is one. And number two, the benefit of TDXT is irrespective of ER positivity. It benefits in minus 2 plus or 1 plus or even in plus 2 plus. So it's irrespective of hormone positivity.
Some, sir, if you look at the forest plot in the DB04, so little bit of higher, like better hazard.
In the ER positive.
Yeah.
Right. But so it's subgroup analysis only, but
Yes, but practically in TNBC one case also I got a very good response. Like that's
right.
what I like wondering. Like, how
right. So even in TNBC with HER2 low, you can. Right.
Yes. Having a case who has responded.
Yeah, I mean, Dr. Ajay was raising this. Yeah, Dr. Ajay was raising this point of regulatory approval, and Destiny Breast 06 is, just was presented in SABCS last year, if I'm not wrong.
Right.
So that is the reason why I was asking this question.
No, that is true. But
I totally agree. Correct. Yeah, I totally agree that there is good data to position it earlier.
Right. So Shri Gopal, I think you mentioned an important point. Even in a triple negative with a low HER2, even there TDXT is working well. That is what you're
Yes,
making, Shri Gopal?
Yes, sir. Yes, sir.
Right.
So having a case who has responded very well, sir, to TDXT.
Right. Right. So basically, you need a HER2 receptor for the ADC to act. That is the biology, right?
Anyone who has an experience with HER2 ultra low yet? Anyone has used in HER2 ultra low?
So I have treated a patient on HER2 ultra low, and post 6 cycles, it's a responding disease, and patient has completed 5 cycles. So I have to see the way forward.
Right. Okay. I think we had a very reasonably good discussion. Fantastic thoughts from all of you. So I would thank all the panelists across the country. So I would request Dr. Shyam Agarwal, sir, if you have anything to say, you can, and then we can conclude.
Yeah, thank you very much, Dr. Chandrakant, and thank you to all the speakers and panelists for really bringing us quite up to date in the management of HR positive, HER2 new negative MBC. So I think the field is really getting very, very crowded, and so many molecules, so many options, and that of course need to be coupled with the molecular testing so as to deliver the best for our patients. So it seems that, as I said in the beginning, it's becoming a chronic disease, good quality of life, long-term survivors. So it looks all pretty good, but then I think the molecular testing should be enhanced. We are missing on I think, good liquid biopsy at this point in time from Indian laboratories. So I think that needs to be pushed into, so that we can figure out these molecular anomalies earlier and maybe pitch in before maybe even they have radiological disease based on, trials like PADA and others. So it's really a very rapidly moving field and exciting field at this point in time. So with this, thanks to everyone for being with us. Over to Astra people. Thank you.
Thank you.
Thank you so much, sir. I mean, on behalf of AstraZeneca, I mean, we would like to thank our program director, Sham sir, and to our moderator, Chandrakant sir, and to all the, distinguished speakers, experts for the excellent discussion and attendees for the participation. So with that, we would like to thank all once again, and we will conclude today's session. Have a great evening and weekend.
Good night.